Let's study the diastolic function of the left ventricle by the evaluation of the Doppler pulmonary vein flow. This is a study done in a left upper pulmonary vein from a transesophageal study. TEE shows very clearly this flow, since this vein is close to the transducer in the esophagus, with the pulse wave sample volume 1 centimeter inside the vein. Notice how is this flow in a normal condition. During left ventricular systole, we see the X or S wave indicating entrance of blood from the vein to the LA. This is the moment of LA reservoir during the systolic period when the left atrium has its greatest size. Then, if the pressure inside the left atrium is increased, the vein will have some difficulty emptying into the left atrium, and there will be a decrease in the amplitude of this wave. But two reasons are responsible for this wave. One is the piston-like effect, as the floor of the left atrium, consistent of the mitral valve, is pulled downward by the left ventricular contraction, sucking the blood from the pulmonary veins and producing a large X wave when the left ventricular systolic function is satisfactory. The other one is left atrial relaxation. Notice that the size of this wave depends on the systolic and the diastolic left ventricular function. During diastole, we see the Y wave that is related with the moment of conduction of the left atrial when blood goes straight from the pulmonary vein to the left atrium and to the left ventricular during diastole. It's related to the left ventricular compliance. Since there is no valve between the left atrium and the pulmonary veins, during left atrial contraction, blood goes to the left ventricle, but we also see a reverse flow back to the pulmonary vein, the A wave, also called the A reverse. Occasionally, we see two X waves, one called X1 and the other X2. The X2 is the one we talked about, its relation with the systolic contraction of the left ventricle in the past slide. X1 is related to left atrial relaxation. Left atrium contracted and sent blood back to the pulmonary vein, the A reverse, and now it relaxes, and some flow will happen from the vein to the left atrium, then the X1 wave before the main flow due to left ventricular contraction, the X2 wave. Many authors show what happened with the pulmonary flow when there is a left ventricular diastolic dysfunction. As usual, its main utility is to differentiate normal from pseudo-normal mitral flow. What we see is that while the left ventricular diastolic function deteriorates, the X waves no longer is the highest wave, and now it's the diastolic Y wave. The decrease of the X wave should be related to the increased pressure inside the left atrium, as well as the associated systolic dysfunction of the left ventricle and diminishing piston-like effect of the left atrial floor. And there is also a greater A wave reverse, since in a left ventricle with poor compliance, the atrial contraction has difficulty to empty inside the left ventricle, and more blood returns to the pulmonary vein. Here we see an abnormal case where the X wave is much lower than the Y wave, what would indicate a diastolic problem, but also may be an indication of systolic left ventricular dysfunction, or also of mitral regurgitation, at least moderate. Then, these conditions should be taken in account. If the mitral flow is normal, then a pulmonary flow like this may indicate pseudonormal or type 2 diastolic dysfunction. One interesting feature is that we can measure the time duration of the A wave in the mitral flow as well as of the A wave reverse in the pulmonary vein. In normal condition, the two waves have about the same duration, or the pulmonary vein A wave is slightly smaller than the mitral A wave. In case of poor compliance of the left ventricle, with type 2, 3, or 4 during left atrial contraction, it needs higher pressure to fill the left ventricle, and it's easier to send blood back to a low-pressure pulmonary vein. Then, the A wave reverse becomes longer, more than 30 milliseconds than the mitral A wave. Here an example. In a normal left ventricular diastolic function, the reverse A wave is of short duration, while in a patient with diastolic type 3 dysfunction, the A reverse has a high amplitude and duration, besides a X wave lower than the Y wave. Here, a comparison with the time duration of the pulmonary reverse A wave with the mitral A wave. The A reverse is more than 30 milliseconds than the A wave, what indicates a capillary wedge pressure usually more than 20 millimeters. The problem with the analysis of this pulmonary vein flow is simple. All I have told so far seems to be of value to study the diastolic function of left ventricle, but mostly using TEE. When we're using transthoracic echo, the story changes. The great majority of adult patients whom we try to obtain this pulmonary vein flow, the success will be very small. Here are two cases, mainly for the investigation of the extent of the reverse A wave, since the pulmonary vein is far away from the transducer where the lateral resolution is poor and with the pulse wave sample volume located 1 centimeter inside the vein. There is no way not to include also the veins walls that have velocity like the flow we want to analyze. We cannot use filters or the flow will also be suppressed. The visualization of this reverse A wave is very difficult. At most we can check if X wave is lower than Y wave. But this sign is not specific. To be frank, I don't waste my time looking for this kind of flow. Look at this example. We are inside the pulmonary vein. It's a normal case. The X wave is greater than the Y wave. But what is the time duration of the A reverse? Very difficult to say. Another example. Pulse wave sample volume in a correct position inside the pulmonary vein. X wave is smaller than Y wave. Abnormal but non-specific. Can't see A wave reverse, just echoes from the wall. Look at this flow. Good to see X and Y waves, and notice the decrease in X wave. But try to measure the A wave reverse. Too much noise from the walls. Occasionally you can get a flow that looks good enough with X, Y, and probably an A wave reverse, which we may be capable to measure. To be frank, I don't waste my time looking for this flow. I have some other methods better to identify the problem of the pseudonormal.